Welcome.
So this patient 6 years ago, the patient once had a palm procedure for the achalasia type 2. So now the patient in recent 1 year still have symptoms such as symphagia and vomiting during the night. So I just cleaning the esophagus. So you see the lumen is still very dilated.
Yes.
And I think the lumen is also very tortuous.
Yes.
Yeah, this is a recurrent patient after 6 years of the initial palm.
And this is the EG junction. So
yes.
about 45 centimeters from the EG junction to the patient's mouth.
I see.
And this is a scar. So 6 years ago, I performed a palm procedure.
So it was a posterior poem.
Yeah, posterior.
I see.
So from barium swollen, we can see the lumen like a sigmoid, and this is a sigmoid type.
Achalasia patient.
Achalasia. So today I want to perform repeated palm for this patient. So we choose the incision of opening of the tunnel at the opposite side of the original opening. And here is a diverticulum change after the first palm procedure. So today I choose the anterior wall of the esophagus. So with the help of the scope, now I can put the scope into the.
For the sake of time, we already studied some procedure,
Yes.
so we can show.
And this is the tunnel.
Yes.
From the tunnel, you can see the muscle is very, very thickened.
Yes.
And the lumen is also very, very tortuous. Okay.
Wow.
So I think it's,
tortuous.
yeah. And this is a really difficult case for the palm procedure.
So are you going to do a short
Today-
myotomy for such a sigmoidal esophagus?
Always short.
Short mile.
Short
Always in our center, always 7 to 8 centimeters.
7 to 8. I see.
I think that here is the EG junction.
Yes.
Now I use the hybrid knife T-type to inject the saline into the submucosal layer, and within the tunnel, the 12 o'clock is the circular muscle,
Yes.
and 6 o'clock is the mucosa. For sigmoid type of achalasia, just as we see that the lumen is very, very tortuous, we always lost direction within the tunnel.
Yes.
How to keep the right direction within the tunnel? Dr. Kai?
Just follow the fibers. You go vertically with the circular muscle fibers so that we won't lost in the tunnel.
Exactly. So here there are many vessels in the each junction area. The working station today I used is Wire 300D from RBA Germany. Here and the setting I always use for the ESD and the palm procedure is endocut cube mode with forced coagulation.
Force coagulation 250 and 324. The setting is.
And this is a time interval. Okay. So with one knife, we can use this type to manage some big vessels. For repeated palm, sometimes there is a severe fibrosis within the EG junction area.
Yes.
So repeated and sufficient enough injection is necessary.
We can see the small scattered spindle vessels from the EG junction. That's one of the markers of the EGJ.
Yes.
Yes.
Here is another big vessel. I use the forceps to coagulate this vessel directly. Yeah.
Yes.
Here is minor bleeding.
Yes.
Okay, stop.
At this place, the hemostasis must be very carefully to avoid injury of the mucosa. But sometimes, if we do the hemostasis, we will use the hybrid knife to do some injection to protect the mucosa and then do the coagulation.
Yes.
Yeah, I am commonly an anterior myectomy person, so we a lot of time encounter big vessels. So there's many endoscopies now changed to posterior. I think one of the reasons is too
Yes.
many big vessels.
So when most endoscopes change to the posterior wall, now I change to the anterior wall.
So you routinely do anterior, or you just select cases?
Just joking.
Yes,
Just
yeah,
Yeah.
the routine is the posterior.
For this specific case, because of the
Previous
already
one.
done posterior wall, yes.
Yes.
Previous posterior was the case we choose anterior wall. I think we can see the fiber changes of the direction to guide that we already in the stomach.
Yes.
For the recurrent cases, so the tunnel should be dissected widely. So now I pull out the scope from the tunnel to check the EG junction.
Yes.
To confirm the end of the tunnel pass through the EG junction. So now we can see the color change at 12 o'clock, and this is the mucosa,
Yes.
and I reflect the scope.
Yes.
Yeah. We can also see the color change in the fundus mucosa.
Yeah, we can see the blue dye. Yes.
Yeah. So now I pull out the scope to cleaning the lens, cleaning the scope. Okay. So I finish the tunnel. So next step is the myotomy.
So actually, in the tortuous esophagus, I think going in, as demonstrated by Professor Zhou, this myotomy anteriorly is not so easy to get in actually at the very beginning. So Professor Zhou is very experienced world, doing the POEM procedure in many cases. So he's looks like very easy, but in fact, in a tortuous way, it's really difficult. Not easy to get in.
Actually, for me, it's very difficult too. Maybe some bleeding, minor bleeding. Yes. Where? So, where is the bleeding comes from?
12 o'clock.
12 o'clock? I think just around the junction. Here is many big vessels within the tunnel around the EG junction. Here, open the knife, please.
For the coagulation, we use the same settings of the force coag 250.
So recently we have many recurrent patients from all over China.
Your referral center, so many endoscopy probably refer to you.
Yes. Now I begin the myotomy from the entrance of the tunnel. Okay. Open the knife. So you see the muscle is still very, very thickened.
Yes, we can see.
It's a regret we cannot have the endo flip in China now.
Ah.
Professor Zhou, what's the experience of endo flip in Hong Kong? Since we don't have that, can you introduce to us?
Yeah, so actually we try a few cases of the endo flip. It's intraoperatively real-time measuring the elasticity at the lower esophageal sphincter. I think it's a device that would allow us to understand the elasticity and distendability of the lower esophageal sphincter. So when we have a complete myotomy, the endo flip results will demonstrate that it's a complete myotomy by improvement in the distendability. But at this, this device is actually quite expensive as well. So we have limited experience also because from the, as mentioned by Professor Zhou, when we are observing the anatomy, actually we know whether we have complete the myotomy. And nowadays also, literature show that we shouldn't actually do too extensive myotomy over the gastric cardia side, not longer than 2 to 3 centimeter. Otherwise, the reflux rate will be much higher.
Okay.
Yes.
So I put the scope into the space between longitudinal muscle and the circular muscle, and push the scope forward.
Ah, I see. So you put the hybrid knife between the muscle and then push the soap so that you can cut. Ah.
Yes.
Okay.
I think you use the same technique even for posterior cases, and it's very fast.
Very fast.
Yeah. I name this technique as pull technique.
Push and pull.
Push and pull.
Push and
Push
pull.
technique.
Okay.
Yeah. So what I do now is push, push, push.
I see. I thought this is
like
more
it-
easy in the posterior poem, but it seems, well, maybe it's because you are doing it, so it looks also very easy in the anterior side as well.
For the interior wall incision, we always hook the tissue and
Yes.
cut it.
Yes.
Because the special design of the T-type, so we can use the tip to hook the circular muscle.
Yes.
Push very fast.
So Philip, how many cases upon finished in Hong Kong now?
So for us, I think we are probably around maybe 300-400. But of course, you have maybe 10,000.
No, sir.
The patient are declined those years because it's a rare disease.
Ah.
In China, many endoscopies now can perform now.
Yeah, but I think very interesting that in the past when we do not have the poem, the patient actually the number was quite limited. But since the development of the poem, we see a lot more patients coming to seek medical treatment for this poem procedure.
Yes. Now we are doing the full thickness myotomy at the anterior wall.
I think one of the important randomized trial that was published in the recent year will be the 2 randomized trial. One is comparing poem against pneumatic dilatation. The other is a POEM compared to halomarotomy. And I think for the pneumatic dilatation, which we are also one of the center, including the cases, the patients did better with a POEM than compared to pneumatic dilatation. So I think that's also with the evidence, we're probably doing more POEM than before for treatment of achalasia.
So we are reaching the end of the tunnel.
And I think this is a gastric muscle.
Yes.
So there may be some bigger vessels in the gastric muscle. So first I calculate the muscle, then cut it. And now the muscle is very thin now.
Yes.
Yes.
Becomes thin, and this is a gastric muscle.
So we are always be very cautious at the end of the tunnel because the myotomy can cause. Sometimes we have big vessels, and sometimes can cause big bleedings at this side.
And now I finish the myotomy.
Very nice. Very fast.
And next, I want to check the each junction. There seems no injury in the mucosa.
So it's wider than.
The junction is wider than before.
Yes.
Oh,
you
yeah,
can
yeah.
see.
Very good result.
Now I recheck the tunnel to ensure there is no bleeding. And with the choreographer, I will manage some small vessels within the tunnel. So the mucosa is very, very second.
The entering is really difficult.
Yeah, I think so. Must be difficult.
With such a dilated esophagus, the angulation to enter the tunnel is gonna be very difficult.
Also, there's a very important tip during the tunneling because we want to know the direction very correctly, and so we dissect very close to the muscle fiber so that we can see where is the direction.
Yes.
And this end of the tunnel, open please. Close. Okay.
Okay, so Pinghong, thank you so much for this wonderful demonstration and a very difficult case, but you did it in just 15 minutes time. Is so quick.
Yes.
So
Thank you so
yeah,
much.
thank you so much. And because of the interest of time, we will be moving to the next session of our workshop. But thank you so much, Pinghong, for Professor Zhou and all the friends from Shanghai, Zhongshan Hospital for the nice demonstration. Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.
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 Bye bye.